Welcome back to part 2 of chapter 33. We're next going to talk about systemic lupus erythematosus. This is a chronic systemic disease that can have inflammation in multi-system organs, including the cells, kidneys, nervous system, the skin. These kids have suppression of the impaired suppression, of the autoreactive B cells. And this immune complex formation can cause tissue damage. They can have vasculitis, ischemia, heart and renal abnormalities. Their alteration in immune function can cause inflammatory damage to organs by the autoantibodies attacking self-antigens. You can find in the body the butterfly or the malar facial rash. It can come abruptly or gradual. There can be fever, fatigue, joint pain. There can be systemic manifestations such as fever, rash, seizures, anemia, pericarditis. Along with skin issues, there can be the joint tenderness. There can be a cardiac friction rub, a pleural rub. You can have lymphadenopathy. You can have hepatosplenomegaly. Diagnostic studies that may be conducted include CBC, ANA, SED rate, CRP, a metabolic screen, antibody testing. Other tests are going to be dependent on what organs may be involved. These are kids that are going to be managed by rheumatologists and may have other subspecialists depending on what some of their issues include. But some differential diagnoses to include maybe infection or malignancy or autoimmune conditions. In the treatment, pharmacology-wise, NSAIDs can be used for arthritic type pains. Steroids may be used for involvement you see in the kidneys, the heart, pulmonary, CNS. You can use anti-malarial drugs for musculoskeletal or skin issues. Immunosuppressants are used sparingly. There is some use of monoclonal antibodies, but these will all be monitored and managed by rheumatology. Vitamin D and calcium, though, are important for bone health if your child is on chronic steroid use. Some complications may include renal failure, involvement in the CNS system, heart attacks, cardiac failure. The severity of this condition with children varies. It's not always a poor prognosis, but supportive care is important. Sunlight can exacerbate things, so sunscreen, rest. We'll talk next briefly on this next condition, fibromyalgia syndrome, which is a chronic pain syndrome with an unknown cause. You can have diffuse non-articular pain and fatigue. It can have numerous trigger points, as you may be familiar with adults. It's more typical in adolescents and females than it is with males. These patients may have fatigue, poor sleep, generalized pain in the muscles, ligaments, and tendons. They are impacted by psychosocial stresses, environmental factors, and they have an increased sensitivity to stimuli. Clinically, you may find that the pain is widespread for greater than 3 months, tenderness at 11 out of the 18 points. These may wax and wane. These kids may also have malaise, paresthesias. They may not sleep well, depression, frequent school absences. On physical exam, pressure may cause pain at any of the points that can be associated with fibromyalgia, but most commonly at the neck, the back, at the lateral epicondyles, the knees. There's no evidence of arthritis or muscle weakness seen with them. This is a rule out other disorders condition. Differential diagnoses can include inflammatory diseases such as lupus, other rheumatoid factors. Management, this can be a chronic lifetime concern. So physical therapy, aerobics, staying busy and active. You want them to keep their muscles as strong as possible. They're going to want to utilize relaxation techniques, may need psychotherapy. Gabapentin can be used to reduce pain sensitivity. patient education, as with everything, good sleep hygiene, trying to manage chronic problems, but the prognosis is good in children. In a similar light is chronic fatigue syndrome. Can be is described as a debilitating, and overwhelming fatigue. It's an unknown cause of pain in children, persistent unexplained fatigue with a new onset, where these kids have a decrease in their activity, and often this follows about 2/3 of the time after a viral pharyngitis or a fever. Clinically, you have to have two of these to be classified for chronic fatigue syndrome. Severe fatigue for greater than 6 months, unexplained by other medical or psychiatric diagnoses. They can have impaired short-term memory, concentration issues, sore throat, cervical or axillary lymphadenopathy, myalgia, headaches, sleep that is not restorative, and then if they've had an exertional event, they can have extreme fatigue and malaise for 24 hours. Differential diagnosis is a diagnosis of exclusion, but you must rule out hepatitis B or C, systemic lupus, cancer, Lyme disease, or any alcohol or drug use. These kids are going to be managed by a specialist. They'll need psychological support and exercise. The literature says the majority of kids will have improvement or complete recovery in 1 to 4 years. Next, let's talk about acute rheumatic fever. This is a complication following a group A strep pharyngeal infection. It's an autoimmune process that can involve the joints, the heart, CNS system, and the subcutaneous tissue. It can reoccur with subsequent strep infections. The revised Jones criteria is used to diagnose rheumatic fever, and you can find that on page 33.5, page 557 in the book. It has a breakdown of criteria for low-risk populations, moderate to high, and high-risk populations, so I encourage you to look at that in the book. Clinically, these kids are going to have had a recent strep infection, which is going to be determined likely, or can be determined, by culture or rapid antigen test. They can have 2 major or 1 major and 2 minor manifestations, and those include carditis, polyarthritis. There is a condition called Sydenham chorea, which is a neurological disorder that can happen after having these infections. That's uncommon. Erytheum, marginatum, and subcu nodules, these are more uncommon. They also may have fever, arthralgia, or a history of acute renal failure. Labs to consider would include a SED rate, CBC, and CRP. You're looking for leukocytosis. You may also want to have an EKG, as there may be a prolonged PR interval. Differential diagnoses include any rising antibody titers. You want to rule out other diseases of arthritis or arthralgia, connective tissue diseases, other bacterial or viral infections, and Lyme disease. Management includes treating the infection, primary prevention to treat within 10 days of onset. I think previously I may have referred to ARF as acute renal failure, but that was a slip up. It should be acute rheumatic fever. So if there's a history of acute rheumatic fever, you want to treat any upper respiratory infections without a positive culture. Anti-inflammatory medications may be used. You may do x-rays, EKGs, referral for congestive heart failure treatment. You're going to be observing for severe chorea, which is a involuntary, irregular, unpredictable muscle movements, and you want to help protect from injury based on this condition. One of the goals of acute rheumatic fever is prevention. And so, as we talked about, treat the infection within 10 days and antibacterial prophylaxis if they have a prior history of this, and there can be the use of antibacterial secondary prophylaxis where you would give penicillin every 4 weeks for 5 years after the last episode, but this will also be in conjunction with specialists. And one of the complications of rheumatic fever would be chronic congestive heart failure. So our last section that we're going to talk about are pediatric vasculitis. And the first one is going to be Henoch-Schloelen purpura. It's the most common vasculitis seen in kids that impacts the small vessels. It's often preceded by an upper respiratory infection. You can have abdominal pain. You can have petechia or a purple rash on the lower extremities, arthritis type of concerns. These kids can have a renal impact. You may see hematuria, protein in the urine, nephrotic syndrome. Is more frequent in the winter and more frequent in males than females. Clinically, they must have purpura petechia in the low extremities with either arthritis, arthralgia, abdominal pain, a slide, smear that says they have immunoglobulin, A deposits, and renal involvement with either hematuria or proteinuria. They also, you will see a history of a previous viral illness. On exam, these kids will have a rash. It's pink maculopapular rash that progresses from red to purple to brown. Arthritis, their joints may be warm. They may have swelling, redness. There can be diffuse abdominal pain, swelling to the scrotum, the eyes, the hands. They can have blood pressure issues. Management is co-managed with pediatric specialists depending on the organ systems that were involved. They may need to be hospitalized. They need to be monitored for GI bleeding. We've already talked about the blood in the urine and proteinuria and hypertension. Analgesics and NSAIDs can be used for the arthritis. Complications may include myosistitis, orchitis. They can have hemorrhagic cystitis, inflammation of lots of places. The pancreas, the gallbladder are less frequent. Arthritis does not reoccur or cause joint damage with this condition. It typically can last 3 to 4 weeks. The rash may wax and wane for up to a year. There can be recurrent disease. Education is important regarding the risk of the recurrence and the need to monitor for nephritis for up to 1 year. And I think our last condition that we're going to talk about is Kawasaki's disease, mucocutaneous lymph node syndrome, or infantile polyarteritis. It's a vasculitis of the medium-sized vessels. The cause is unknown. An infectious agent may activate the immune system. Kawasaki's typically presents in the late winter and early spring, and person-to-person spread is low. The criteria for Kawasaki's includes a persistent fever for at least 5 days, plus 4 of the following: bilateral conjunctival injection, changes in the lips or the mucosa of the mouth, swelling in the cervical lymph nodes, polymorphous exanthema, where there is mucosal changes in the lips and in the oral cavity, and then swelling to the hands and feet or the perineal area. Clinically, these kids may have some coronary anomalies noted on EKG. Atypical Kawasaki's is more common in children less than 1 or greater than 9. Some other clinical features include irritability, aseptic meningitis, and iriditis and uveitis. It is broken down into different stages. The acute phase is days 0 through 14, and it is associated with high fever that may be unresponsive to medications, irritability, a strawberry tongue, which is one of the classic signs of Kawasaki's disease, lymph node swelling. on stage 2, the subacute phase, 2 to 4 weeks. The fever has resolved. Irritability may be maintained. There may be transient jaundice, abnormal LFTs, orchitis. There may be some facial palsy. In the convalescent phase, 6 to 8 weeks, all clinical signs have resolved, but lab values have not returned to normal. There can be nail changes, and coronary complications may persist until adulthood. Diagnostic studies, the diagnosis is made by exclusion. Acute phase reactants may be normal early on. WBCs may be increased. You may have thrombocytosis with platelets greater than 1 million in the subacute phase. Management includes early diagnosis to prevent aneurysms. IVIG may be used to reduce coronary artery abnormalities. High-dose aspirin may be part of this. This is obviously a child that is going to be managed by a specialist, but just to be made aware of some of the treatment modalities that may be used. Assessment of the heart is going to be important as soon as possible, and then periodically thereafter. These kids are going to need a delay in vaccines for up to 11 months after receiving IVIG, so that is important to be aware of. Cardiology consult, if there were no coronary issues when first diagnosed, to be reassessed, because that can go on indefinitely. And then education on healthy diet. And then education of patients. This is typically an acute disease that's self-limited. Reoccurrence is less than 2%. You can have congestive heart failure or a massive MI, myocarditis and pericarditis in approximately 30% of these children. Mortality is at about 1.25% related to cardiac complications, and the risk of a coronary aneurysm is reduced if IVIG is given within 10 days of onset, and an aneurysm regression occurs in about half of these patients. So I believe that is the end of the second part, and if you have any questions or concerns regarding Chapter 33, please let me know. Thank you.